Hey, CEimpact subscribers. Welcome to the Game Changers Clinical Conversations podcast. I'm your host, Josh Kinsey, and as always, I'm excited about our conversation today. Asthma remains a common yet often mismanaged condition with poor control, leading to preventable symptoms, hospitalizations, and reduced quality of life. In today's episode, we'll cover recent treatment updates, counseling strategies, and the pivotal role pharmacists play in helping patients breathe easier and live better. Before I introduce today's guest, I wanted to share that we've launched a special pilot series in collaboration with our friends at Pyrls, a modern drug information resource and app. These crossover episodes, called Game-Changing Pyrls, see what we did there, combine Pyrls' trusted evidence-based clinical tools with CEimpact's expertise in pharmacy education and accreditation, bringing you timely, actionable content that supports both your practice and your professional development. It's a privilege to work alongside the Pyrls team, and we are excited to kick off this pilot series with today's episode focused on the management of asthma. And representing Pyrls today is Rachel Maynard. It's so great to have you as our guest today, Rachel. Welcome.
Thanks so much, Josh. So excited to be here.
Yeah, and I know that you have a busy schedule, so we are so grateful that you took time out of your schedule to sit with us today and talk about asthma. And for our listeners, since it's probably the first time they've met you or heard from you, if you want to take a couple minutes to tell us a little bit about yourself and maybe how you started in pharmacy and some of your passions, and just tell us all about yourself.
Yeah, sure. So yes, my background originally was in community pharmacy. I started working as a technician while getting my undergrad degree, and that's what drove me to go to pharmacy school. After pharmacy school, I did a community pharmacy residency and practiced as a staff pharmacist for a few years, and also providing clinical services for a grocery store chain and also managing those services for a regional group of chains. So after that, I then sort of moved into the drug information and education space, writing, creating content for healthcare professionals. And I have done that for now over a decade. And most recently, I've been with Pyrls in, again, a very similar role, sort of helping to manage the editorial process, our content development process, and to really ensure that we're providing resources and education and tools for clinicians to help them optimize patient care. And that's really what I'm passionate about, is knowing what it's like in a community pharmacy and how challenging that can be, making sure they have the tools they need to practice to the best of their ability. Yeah. And for our topic today, like asthma is one of those topics that I think we see so many patients with, and we can make such an impact on their lives. And so I'm super excited to be here to chat about that.
Yeah, that's great. And, you know, a lot of our discussion for today is going to focus around some of those things that you can do with the patient at the counter and like making sure to improve adherence and whatever. But in general, you know, asthma is one of those disease states that every pharmacist, regardless of what role they're in, it probably has encountered a patient with it. And so even, you know, some of these nuggets that we're going to share today, you know, they can be implemented anywhere in your practice setting. So I'm really excited. I feel like asthma is one of those things that is super important and really detrimental to a patient's quality of life. And I feel like sometimes we don't talk about it enough because I just feel like we need to elevate it more and really focus on how can we make the quality of life for these patients better. So super excited about our talk today. So thanks again for joining us. We really appreciate it. And just really excited about this partnership with Pyrls. So, all right. So let's go ahead and jump in. Just as I always like to do, lay the groundwork and the foundation, make sure everybody's on the same page. So let's just have a brief review of asthma in general, and maybe just a reminder of, you know, how is that different than, a chronic perspective of that, like COPD and whatever, like, you know, because sometimes those kind of get blurred because inhalers are used for both sometimes. So let's just kind of have a quick review of asthma and just kind of talk a little bit about that and lay the groundwork there.
Sure. So in a nutshell, it's, as you said, chronic inflammatory condition of the airways. And so if you think about how asthma is diagnosed, there's really sort of two components of that. It's these respiratory symptoms, which are sort of those classic symptoms you think of, like wheezing, cough, shortness of breath. And then there's this variable expiratory airflow. So, assessing whether there's reduced ability to exhale because of that inflammation. And so that's why it makes sense that inhaled corticosteroids are a foundational treatment for asthma because of that inflammation and that variable airflow.
Sure.
In terms of differentiating from COPD, that can be tricky because there are, there's overlap in symptoms with the cough, the shortness of breath. I think some of the differentiators are things like if you're waking up at night with symptoms, that's more indicative of asthma. If you have a patient who is also has allergies, for example, like allergic rhinitis or eczema, those can also be sort of cues that it might be more related to asthma. Whereas if you have an older patient, that can be challenging because, there's sometimes some overlap there, but also thinking about a history of smoking. And if, COPD is almost always associated with a history of smoking. And so that's another cue to think about. But I will say, smoking is also a trigger for asthma symptoms too. And so even though there's overlap, there can also be this, people can have both. They can have features of both. And even though there's variable expiratory airflow with asthma, if you've had asthma for a long time, some adults may have more persistent airflow problems. And that can also be more similar to COPD, where there's this more persistent airflow limitations. So that's why it's tricky. I will say in the most recent updated asthma guidelines that we'll chat about a little bit more, they actually called out what term to use. So you may have heard this term asthma COPD overlap, and that was sort of the term that we used to use because it was, just a way to think about these two conditions overlapping and the fact that they have similar symptoms and diagnostic process and that sort of thing.
Sure.
They are now encouraging people to use the term asthma plus COPD so that it's not seen as like a separate condition. It's more so that people have features of both. And so I thought that was just sort of an interesting nuance that they're calling out asthma plus COPD versus overlap, because that's inherent, but really these patients have features of both asthma and COPD.
Yeah. And I think, Rachel, one of the things that I don't know that I thought this, but I feel like it was, I feel like the general population thinks this sometimes, is that asthma is for kids and COPD is for adults. And that is, we need to make sure that we're not on that wavelength because that is not true, correct? I mean, there are plenty of adults that have asthma and only asthma and maybe, like you said, overlap as well, but that is not the case. You can't just look at it as children have asthma and adults have COPD when they get older. So,
I mean, I'll say that I think that you can use that as a differentiator to help, again, sort of figure out what the patient has. Is asthma
is their age definitive.
Right. But I looked up some stats when thinking about this topic, and 9% of adults in the U.S. have asthma versus 7% of kids, and so it's very common in adults, and so yes, I think that's a good distinction to make.
Yeah, very good. Okay, so, and as you mentioned, this is kind of a great kind of lead in here. It does affect millions of patients across different age groups. You gave some great stats there, 9%, 7%. I mean, that's quite significant when you think about that. And I think just reiterating the fact that, why we're here today is to talk about how proper management can significantly increase the quality of life, decrease hospitalizations, reduce healthcare utilization in general, funding, cost, whatever. And it just an overall reason for us as pharmacists to jump in because we have great access to the patients. They have great access to us. And, these slight little tweaks can really make a difference. So I think that's really what I'm excited to dig into today is how, just a few little things that you can do and can really change the patient's quality of life. So with that, what are some of the roles of the pharmacist? So I know we're going to dig into them deeper, but what do you feel like, where do you feel like pharmacists can interject themselves here with asthma and with asthma patients?
So I think there's so many opportunities, again, regardless of your practice setting. But one of the keys with asthma is that it's not just a set it and forget it sort of condition. It's something that, patients need to be assessed and their medications reviewed and adjusted as needed, sort of on this, cyclical basis.
Yeah.
And so the idea that, like you say, patients are coming in for refills or even, for whatever reason into the pharmacy, and just having that opportunity to have these frequent touch points with them, it's just such a prime opportunity to reassess how their asthma is being managed, how they're using their inhalers, if they're using it properly. So I would say that's one of the biggest opportunities, is just thinking about those frequent touch points and the fact that we can really make an impact on adherence to medications, but also how to use those medications properly, and also, keeping an eye on things like vaccinations and preventing triggers and, other comorbid conditions that can worsen asthma, like obesity or GERD. All of these things sort of are just a prime opportunity for us, I think.
Yeah, I'm glad you mentioned vaccines, because that's a big one. The guidelines call out specifically that section of the population, and there are, certain things that are recommended for them, and so I think that's really important too. And I love the idea. I mean, we should be doing cyclical type interventions with our patients in every disease state, but this one, certainly. And also thinking about too, again, especially if it's a child who has asthma, as they grow, as their body changes, as their hormones change and the way that they metabolize. I mean, we may have to adjust doses as they grow older. So, just things, thinking about that too. Like, you can't just be like, okay, they're on a maintenance inhaler and they're on a rescue inhaler and they're good till they're 25 or whatever. Like, that's just not going to be the case. So,
well, and honestly, sorry, Josh, I mean, I think one of the things, is even like a decade ago, the way we thought about managing asthma is very different than I think what guidelines are recommending now. Whether or not all of those changes to the guidelines can be implemented in practice is another story. But there's been quite a change in thinking over the last few years. And so even if a patient's been on therapy for a while, if they're not well managed, it could be an opportunity to relook at that and see if there's an opportunity to improve.
Yeah, that's great. And you bring us to our next subject. So perfect. Let's talk about guidelines. So one of the opportunities for pharmacists is to make sure that we are up to date on the guidelines for the treatment and management of asthma. So let's talk a little bit about what that looks like. And I know that we're going to utilize a wonderful resource from Pyrls. So I'll let you kind of guide me on when to share that screen. But yeah, let's talk a little bit about the importance of the guidelines and making sure that we're up to date on those.
Sure. So the guidelines are the ones that I think many clinicians are following these days are from the Global Initiative for Asthma, or GINA guidelines. And those are nice because they come out every year. And so they just came out in May, a couple of weeks ago. And it allows us to sort of keep on top of what's changing, what evidence is coming out, how can we improve, standard of care. Even little things like I mentioned, that asthma plus COPD versus asthma COPD overlap and some preferred terminology, that sort of thing. They address that too. So I think that's typically where people are following are these GINA guidelines. There were guidelines, and GINA is international, so it's not country specific, whereas there are US-based guidelines that you might remember from the National Health, Lung, and Blood Institute from like 2007. So more almost 20 years ago. And those are still in place. They did come out with a more focused update in 2020, looking at just a few key things. And so that was sort of where the concept of smart therapy, which I'm sure we'll talk about, came out on the US side of things. And then again, GINA has sort of been iterating on that over the past few years as well. So I just say that because there's a couple different sets of guidelines, but I think just from a frequency of updates perspective, the GINA guidelines are where a lot of us tend to rely on. And so, to that end, what we've been working on at Pyrls just recently is updating our pharmacotherapy review, which is like a cliff notes sort of how you approach a patient with asthma, and updating that to reflect these most recent guidelines that just came out.
Yeah, that's great. That's great. Do you want to jump into some of those stepwise?
Let's go for it. And so, you can share the chart that we have, which is, as you said, sort of a stepwise approach. And we have it outlined for both adolescents and adults, so 12 and older, and then also for younger children. But in terms of just thinking generally, especially about this broad population of our adolescents and adults, you can see there's sort of this preferred approach and then also an alternative approach. And the preferred approach is really where GINA recommends that most patients start. And the focus is on making sure that patients at diagnosis or soon thereafter are incorporating an inhaled steroid into their therapy in some way. And that's to, again, help reduce that inflammation and help manage and also prevent symptoms and exacerbations going forward. So with either the preferred or the alternative approach, the idea is that the patient will have both a controller medication and a reliever medication. And so the controller, as the name implies, it helps to manage those symptoms and prevent future symptoms. That reliever is to help with as needed, when wheezing, coughing, those asthma symptoms crop up, to help provide that quick relief. But I will say, this was another thing that I sort of learned as we were doing this most recent update. The idea of controller versus maintenance is I was thinking of them as sort of synonymous. And again, I think that's because we've had this idea that, you have your quick relief inhaler and then you also have your maintenance inhaler that you take every day to prevent symptoms. But with the more recent guidelines, there's been this focus on incorporating your inhaled steroid along with your reliever, and whether that's a short-acting beta agonist or a long-acting beta agonist, like formoterol specifically. The idea is helping the patient get that inhaled steroid at the same time they're getting their quick relief medication. So the idea of a controller could actually be something that a patient is using only as needed if they have their inhaled steroid formoterol combo and they're only using it as needed for more mild asthma. It's still helping to control their symptoms, right? It's not something they need to use every day. And so I thought that was a really interesting distinction, just this idea of controller versus maintenance not being interchangeable, and, sort of this new paradigm about incorporating inhaled steroids and more of that, even as needed therapy.
Yeah. Well, I was going to ask, because I used the term rescue inhaler earlier, I was going to ask if that's been replaced with reliever. So is that the case? Like, is that pretty much?
That's a good question. I didn't see anything in the guidelines about that specifically. They do say that people often do refer to it as a rescue inhaler. It's really just for that quick relief of symptoms. Right. I think what I've heard in the past about the concern with the term rescue is that, like, it's not meant to be. Yes, it relieves your symptoms quickly, but it's not meant to be used like if you're having an acute exacerbation and you might need, to go to the hospital or something. So,
Sure.
but with the growth of sort of these combo inhalers with a formoterol with an inhaled steroid, or even the more recent product that's come out in the last couple of years, which has albuterol with an inhaled steroid, the idea is that hopefully it will be less, rescue, because you're getting that steroid along with your quick relief.
Sure. Yeah. No, I appreciate that approach in the sense of rescue kind of indicates, like, oh, this takes care of an emergency situation, as opposed to it really shouldn't. Like, if it's a really dire situation, you should be seeking emergent care. And so reliever is, okay, I can see that. That makes sense. Okay. Well, also, these charts are so good. I mean, they're so, I am your typical type A pharmacist who just loves, colors and flow. And I always, my family and friends, whenever they visit or whenever we go on a trip, I have a color-coded itinerary for our trip. And so I always get poked fun at for all of my color coding. And I even work in this is when we relax in the room for 30 minutes.
Wow.
So I love these charts. This speaks my language right here. And they're so good, and they're so easy to have on hand, just to help with your patients as you're managing asthma. And this is just one disease state where we're looking at something that Pyrls has. So these are just so great. And for the listeners, just I didn't really mention it, but these all the charts that we're showing, all the handouts and resources that we're showing are going to be available in your profile. So be sure to grab these. You'll be able to have access to them. So okay. So with that, let me get back to my notes here. So let's talk a little bit about, we've kind of gone over the importance of the guideline, making sure that understanding why is that important for the pharmacist to stay up to date on it, because like you've said, they change every year, and sometimes those nuances are, it's important to note them. So let's talk about the role of pharmacists in counseling, specifically with inhaler technique to ensure that patients are getting the right delivery of the medication. And, I've seen so many patients over the years just do it so wrong. And it's so sad because, it's just a simple discussion that can be had, and showing of technique. So I'd like for you to talk a little bit about the importance of that.
Yeah. I mean, I think you're spot on. It seems like something that it's simple, but not necessarily easy, right? Like, so
For sure.
the
For
idea
sure.
that like, it's something that we should be able to tackle and patients should be able to tackle, but every inhaler is different. They all have their little nuances in terms of preparation and cleaning and,
And it's not super intuitive. Like
no,
sometimes I've even looked at a new one and been like, what do I do?
right,
And
right.
yeah, so I
And
totally
thinking
agree.
about like limited time too, we all have limited time. And so to like have to open up a package and open up the label and like help a patient walk through that can be a big barrier. And so, yeah, I think in the guidelines, I think they said like up to 70 or 80% of patients have trouble using their inhaler, don't use it properly.
Right.
So it's like a huge number, but also that many healthcare professionals, as you said, don't always know how to properly instruct if they're not intimately familiar with the product either. So,
Yep.
yeah, actually, so within, the Pyrls drug summary pages in our counseling points, we have these key counseling points to just drill in on that you want to focus on with the patient. And right in there is the administration guide for these inhalers. So you can just pop that up with that, again, out having to like open up their package and
Yep.
sort through the label. So just open that up and then walk through it with the patient. But I would say
Great.
like, it's sort of that classic teach back method. So walking them through the steps as you would normally counsel a patient, and then having them teach you back how they would do it, and then pointing out any errors or opportunities for correction. But each inhaler is different, as we said, and then there's the metered dose inhalers, which are a little different from the dry powder inhalers and require different techniques. And so, yeah, it's definitely a challenge, but something that is just right within our wheelhouse and such a good opportunity to impact
Absolutely.
care.
Absolutely. And, I'd be remiss if we didn't talk about during counseling, reiterating the importance of adherence, because
Oh, absolutely. Yeah.
yeah, that is going
Hand
to
in
be,
hand.
yeah, that is going to be something that is super important for specifically this disease state, because if they're adherent on, the regular, what is it now?
Their
Controller? Is that right?
controller.
Yeah. If they're adherent with their controller medications now, then, they're going to be able to use less and less of those reliever products and have less and less exacerbations that require, some sort of emergent care, hospitalization, whatever, which is our goal. Like, we're trying to improve their quality of life and reduce the burden on healthcare, so yeah, so adherence is also super important to talk about with patients along with the technique. Yeah.
And so just to like expand on that a little bit, because again, this concept of how asthma is managed has changed in the last decade or so a little bit. And so like the idea of your inhaled steroid is your controller, you do that every day, and then you have your albuterol, which is your quick reliever, and you're doing those together. But really the guidelines in the past few years have encouraged this smart therapy, so single inhaler maintenance and reliever therapy all in one inhaler. And so that makes it so much easier for patients because it's just one inhaler. They don't have to think about, well, I use this for this and this for this. It's one inhaler, and they can use that combo inhaler for their quick relief of symptoms and for their daily maintenance. And so that hopefully helps to simplify things. But also, if you have a patient with more mild asthma and maybe they're not on an inhaler every day, but they are using it when they have symptoms, and they're getting that inhaled steroid dose because they're taking that combo product. Adherence means a little differently there, but it's like making sure that they are using it when they have symptoms, and they know they can, they know that they're using that instead of maybe they had albuterol in the past, and, understanding why they're maybe now using that combo inhaler.
Absolutely. Yep.
So yeah, it's, I will say also thinking about adherence though, even though the smart therapy has been sort of, the preferred treatment now, I think cost and insurance issues can be a barrier.
Oh, for
So,
sure. For sure.
if you're using smart therapy and you're using your maintenance dose, but you're also supposed to be using it as a reliever, then sometimes insurance will pay for that additional dosing. And
Right.
so, yeah, we
Right.
have to
Because
make sure that
you would run out of it sooner than
exactly.
what,
Yep.
like how
Yeah.
do you monitor that day's supply? Yeah,
Yeah.
exactly. And again, that goes back to your point earlier where you were talking about this is a cyclical management for
Yeah.
these patients because, what if you see like, oh, they're coming in every 18 days for this, then clearly
Hmm.
maybe the dose is not right. Maybe they're not as controlled as we thought, because they're using it so much more often. And, that's what we as pharmacists can see. We can see when they're requesting the refill too soon, or,
Hmm.
if we're on the provider side of it, we can see when the refills are coming in as requests too
Hmm.
soon and things like that. So yeah, like in an AmCare setting or whatnot, where we're working to actually manage the care. So yeah, that's great. The other thing to talk about, I think, that's important in adherence is also um, talk about in counseling along with adherence is also the importance of trigger avoidance. Can you
Hmm.
speak a little bit to that? Is there anything you want to talk about there?
Yeah. So again, that's a great opportunity for us to be listening to what patients are talking about, just even in conversation as you're just chatting with them about other things. Right now, allergy season is sort of in full swing, and that can be a trigger for many patients with asthma. So being aware of that. Again, smoking can be a trigger. So if a patient does smoke or vapes, pointing out that this could be contributing to the worsening of your symptoms and helping them on that journey to quit if possible.
Mm-hmm.
There's also, a viral infection that could be a trigger. So helping patients stay healthy again through
Sure.
vaccination. And so, yeah, I mean, again, there's seeing patients and if they're getting, an over-the-counter histamine or something, or you see them sneezing and, these sorts of things can be a cue to be like, hey, did you also know that this could impact your asthma management
Mm-hmm.
too? And maybe
Mm-hmm.
we need to think about, monitoring closely if you're having some sort of viral infection or allergies or whatever the case may be.
Absolutely. Absolutely. Yeah, those are all great points. Um, so I think we've kind of hit on our major points that I wanted to be sure we talked about today. I want to also show your other couple of resources that are going to be available to listeners. Um, so I'll just kind of share and you can kind of just quickly let us know what we're looking at here. Um,
Yeah. So we Pearls at Pearls we have this really fabulous inhaler chart that compares the dose categorizations for inhaled steroid combo products. So various inhalers that have inhaled steroids, you can sort them into low, medium, or high dose. Again, that's based on the GINA guidelines. And it can be challenging to sort of quickly compare what dose a patient might be on and what they might need to switch to. And again, this goes back to the idea of like adherence and making sure we're overcoming cost barriers for patients, because insurance plans change, insurance formularies change, and
yep.
patients may all of a sudden be not able to get the inhaler that they've taken for years. And so
Absolutely.
this chart allows you to very quickly compare, okay, if a patient's on mometasone and they're going to switch to fluticasone at a medium dose, here's how you would do it with the number of puffs per day.
Mm,
And it's, again, sorted by ages 12 and older and pediatrics. So a very quick
good.
and easy way to help those patients switch if formulary issues come up. And I will just say, with both the step therapy chart and this corticosteroid comparison chart, it is meant and is used as a way to like keep it very simple, but also, being aware that, like everything in pharmacy, nothing is cookbook, one size fits all.
Exactly.
It has to be very individualized and patient
Exactly.
focused. And so after any switch, we also still want to encourage patients to be monitoring their symptoms, being aware of any
Yep.
worsening of asthma, because everyone's going to respond differently to their particular product. So
Mhm.
it's just a good reminder to, after any switch or when starting, circling back with that patient again to see how they're doing.
Yep. So it's a great guidance document. It is not the gospel truth, like it's, yeah, exactly. And then this one, which I also love, again, love the color coding, love the, love the flow of everything. And just the summary of it's just so good. So I'll let you kind of speak to this one really quick too.
Yeah, so this is an inhaler comparison chart. And like you say, it's very nice to look at. There's not a lot of things that you're looking at on paper that you're like, oh, this looks nice to look at. But this, I would say, it's very, like you say, color coded. It's sorted by class. So inhaled steroids versus LABAs versus LAMA-LABAs and combos. So very easy to quickly find what you might be looking for in terms of which drugs are in a specific class. It also notes which ones are approved for asthma versus COPD. So helping with that indication and also with the approved age ranges. And then there's dose categorizations in there too. So helping, again, if you need to switch between doses of particular steroids, helps with that conversion as well. And it also, by the way, notes which products are available as generics or authorized generics. So again, if you're running into insurance issues, that can be another clue to help with those barriers.
Absolutely. Yeah. And one thing you mentioned earlier, and this is kind of just to summarize and reinforce the importance of counseling and adherence and, talking about the triggers and that kind of thing. One thing you mentioned was vaping. And I heard recently the percentage of patients that vape, and it's staggering. And I feel like we're back in that cycle of, the whole, what was it, probably the 60s and 70s when smoking, the issues really came to light, really started, downplaying it and whatever. But I just feel like we're back there again in a similar situation. So I love that you pointed that out, because that's a trigger for those patients. And that's something that we need to be sure that we're talking about, because I don't feel like we're always talking about, we always mention smoking, but people who vape don't think they smoke. And so so making sure to point out the vaping, I think, is just really important. So yeah. Okay. Well, this has been so much great information, Rachel, just so good. And just so excited to have you on today and to discuss this and to show how these great resources from Pyrls just can really help our pharmacists out. That's our whole goal, is to make it easier for our pharmacists, because we know that they're overworked. We know that their workflow is difficult. We know that they have, limited time. And so if there's anything that we can do to make that time more special and more dedicated to that patient, and if we can train them in certain ways to be able to be more, effortless with that counseling, then that's our goal. So these are just such great supplements to the education that we already provide. So this is great. So what I always ask everyone, all my guests at the end, we've given lots of nuggets today that I hope our listeners walk away with. But what would you say, Rachel, is our game changer here? So what's our real big take home as pharmacists in the space of asthma management?
Well, I think, we can't say it enough that those touch points that are sort of built in naturally to some of our interactions with patients are just the prime opportunity to be able to reassess inhaler technique, reassess adherence, help correct any issues that might be coming up, identifying triggers, all of those things. We didn't specifically say this, I don't think, but, another thing that ties into that is, before recommending any change in therapy or encouraging a patient to, change their dosing or something like that, always assessing inhaler technique and adherence before recommending any change to a colleague or prescriber, because it could just be a little correction can help them get the most benefit from their medication and really improve their symptoms. So, and prevent those exacerbations and ED visits. So
that's a great point, in that, don't always jump to the fact that you need to up the dose
exactly,
or drug, because it could just be that they're not getting it with proper
And on the flip side, I'll just throw in one more point here.
Please.
So we talk about often stepping up therapy, but also if you've had a patient who's well managed and after a few months is stable, think about stepping down too. It's steps go both ways. So that's also something that the guidelines were, consider when you may be able to step down if a patient's doing well, especially if they changed therapy recently.
Great point. And that's not something that is super common with a lot of the disease states that we manage.
Right.
Is like, okay, well, let's just take them off of stuff.
Right.
So that's really a great point to highlight. So thank you. Well, again, Rachel, so good. It's been great to have you on this week. Thank you so much for joining us. We really appreciate the partnership, and we appreciate your time today.
Thank you so much. This was fun. Glad to be here and glad to support Pyrls here with CEimpact.
Great. Thank you. If you're a CE Plan subscriber, be sure to claim your CE credit for this episode of Game Changers by logging in at CEimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you again soon.